Good evening, everyone. Welcome. All right. Hi, my name is Alexis Redmond, and I am the Senior Director for National NSSLHA. I want to thank you for coming to tonight's National NSSLHA Town Hall. I, on behalf of the Executive Council, um, know how stressful and overwhelming it has been being alerted about the Medicare changes, and we thought that this event would be a great opportunity to provide support, resources, and focus on how to navigate these changes. During tonight's event, we will hear from members of ASHA's Government Affairs and Public Policy team, their SLP Healthcare Services team, and the ASHA Certification team. This event is meant to be an open discussion. So please ask questions via the Q&A feature found on your Zoom bar. All of tonight's questions have come from either the Q&A or the questions you submitted during registration. So if at any time you have a question, please pop it in the Q&A. We'll answer as many as we can during this evening, as well as typing answers into the chat. This event is being recorded and will provide a post-event summary, which will include additional links and resources that you can refer back to, as well as share with others of your classmates and colleagues. So with that, I'd like to introduce our panel. We have Monica Sampson, Rebecca Bowen, Amanda Gallagher, and Brooke Hatfield. I'll have each one of them introduce themselves and share their role at ASHA, starting with Monica.
Hi, everyone. My name is Monica Sampson. I'm the Chief Staff Officer for Speech Language Pathology here at ASHA. And I'm an SLP, a medical SLP by background, with my experience primarily being in skilled nursing facilities and outpatient. And Becky, I'll toss it to you.
Great, thank you. Thanks everyone for being here this evening. My name is Rebecca Bowen, and I'm also an SLP, primarily in home health, a little bit of outpatient, some inpatient as well. So on the medical side, I serve as ASHA's Director of Healthcare Policy for Value and Innovation. So looking at rules, regulations, and upcoming payment models.
All right, Brooke.
Good evening, everyone. My name is Brooke Hatfield. I'm the Senior Director for Healthcare Services and Speech Language Pathology at ASHA. The Healthcare Services team focuses on clinical and professional areas in healthcare settings, really across the continuum of care. So our team members support clinical topics in the areas of mostly acquired disorders and swallowing, and then we represent practice settings ranging from everything from hospitals to medically focused home health. And just on a personal note, I also have a background as a speech language pathologist in different healthcare settings. And I met someone with aphasia when I was an undergrad, and that was it for me. I knew I was never going to work in any setting other than that. And I remember the excitement of that transition from education to work. And I just want to say that I see all of you who are feeling this, that your rug just got pulled up from underneath you, either for what is happening or what might happen ahead. So know that we feel this with you.
Thank you. And Amanda.
Hi, everyone. My name is Amanda Gallagher. I'm the Director of Clinical Certification. So I am on our certification team here to support folks who are applying for certification, who hold certification and are looking to maintain, and the graduate programs who train those individuals. I am also a medical SLP by background, and about 15 years worth of my experience was in outpatient adult neuro rehab.
All right, great. So on June 9th, ASHA members received a message, as well as National NSSLHA members, about the changes at Medicare. So Monica, could you give us a little bit of an overview of kind of what's happening with Medicare? I know it's been a bit of a whirlwind for all of us.
Absolutely. So what has happened is that CMS, the Center for Medicare and Medicaid Services, has several parts to its policy development process. The almost final component of it is the Medicare Benefit Policy Manual, which is, if you look at it as sort of like a standard operating procedures kind of manual that local Medicare administrative contractors refer to for implementation. Now, the Medicare Benefit Policy Manual highlighted a change in the qualified provider for an SLP. The change was made back in 2015, but it was communicated in 2025. And it was sent via email communication to providers, which is essentially how CMS communicates. They send email updates, and this was a decade late in updates. We have no background information yet as to why the updates were made now or communicated now. The updates were made a decade ago, and why it was shared at this point. But the change indicated that to be a qualified provider under Medicare and to bill Medicare Part B, which is outpatient services, you needed to either have a state licensure, or in states that do not offer licensure, you need to hold the equivalent of the credentials required to obtain your certification, ASHA certification. Now, when we got the status, when SLPs got the status to bill Medicare back in 2008, and it was, and we got the requirements fleshed out in 2009, what we had in place was a phrase that indicated that you were either certified or you were in the process of obtaining the certification. That language is missing in the new update that we were reviewing. And so we also heard that there are Medicare administrative contractors who are not credentialing those who hold provisional licenses, who are essentially clinical fellows under ASHA's umbrella. Given the circumstances, ASHA reached out to CMS staff to get clarification about this, and they responded back indicating that as it stands right now, as their staff are currently interpreting it, provisional licensees are not qualified providers. And you can find the exact language listed in the web resource. It's an FAQ resource. You'll see timelines listed there as well. But that is essentially what prompted us to communicate that very critical piece of information to ASHA membership as well as NSSLHA membership.
All right, thank you. So seems like there's a lot of moving pieces. So Becky, maybe you can kind of help what in the simplest terms, what does this mean for CFs and for provisional licensees like for right now?
Yeah, it's definitely a very tricky and I'll say dynamic situation. We have the initial guidance from CMS staff, and we're actively trying to get additional clarification and get a meeting with CMS. So, we're talking today, on June 24th, how things stand right now. And it is a very tricky situation. So with that policy change, with provisional licensure no longer being considered a qualified provider, it makes that change in that in the past you would have been able to bill Medicare independently as a clinical fellow. You would have a provisional or a temporary or conditional license, and you would be able to bill that independently. But now with this new interpretation, essentially CMS is treating CFs as students, not as independent practitioners. So those supervision requirements come into play, and we can talk a little more about those, and we can put some of that information in the chat. But essentially, you're not being treated as an SLP, you're being treated as a student in the eyes of Medicare for Part B patients. Now, where that gets a little bit sticky is, some employers are okay with that, and they're willing to continue to keep a CF on, and they have someone who's able to supervise, etc. But there are some employers who don't feel like that is viable for their business model, and they're saying, in this situation, we're not going to accept CFs because they aren't able to bill independently. So that's kind of the long and short of it, but it is a significant change that we know is having impacts on all of you.
Thank you. So from what I heard and Monica saying, it applies to Part B. So with Part B, what settings are under that purview? And then what settings can provisional licensees and CFs continue to work in that aren't impacted by this policy? Brooke, could you give us some perspective on that?
Yeah, sure. And I think Becky teed it up really nicely that I want to just keep in mind the distinction of not being able to work versus not being able to bill. And I recognize that this is a very fine nit to pick, but I do think it's an important difference. So it's not that someone on a provisional license can't work in facilities that are covered, that see Medicare. I'm going to use Medicare broadly here because there's a little bit of distinction between A and B as I walk through the settings, and then I'm happy to try to give more detail as questions require. So it really is a billing related to supervision issue. So let's just sort of step back and take a look at the settings where Medicare is not traditionally a strong payer. And I just want to put a little asterisk aside of everything that comes out of all of our mouths here, that there's always exceptions to every single rule, and to make sure that you and your facility are asking questions. So we can't blanket say always in X setting or always in Y setting. But settings where Medicare is less likely to be a payer, school-based settings, state early intervention programs, pediatric private practices, pediatric medical settings, and VA health systems are the first ones that come to mind. Medicare is the payer for people who are Medicare eligible, and those tend to be older adults and folks with chronic illnesses. So
Hi,
you can,
Brooke. I'm sorry to interrupt you, but your volume is fading just a bit. I don't know if
oh,
your mic has.
I have no solution for that other than to try to put a
Wait,
little
wait.
more umph under it. Did that work?
That is
Okay.
better.
Oh, wow. Okay. So should I won't do all of that again, but I will say, so with apologies, that it really is dependent on the type of person that is typically seen in that setting. So your client population. Medicare is the payer for folks who are over 65 or have chronic illnesses, some chronic illnesses. So settings where people tend to be under that demographic are less likely to be impacted by Medicare. So again, apologies if this is a repeat, but schools, state early intervention programs, pediatric private practices, pediatric medical settings, and VA health systems are the first ones that come to mind. But there are some other considerations. Again, this is a distinction of you can't bill independently, but not work. So residential facilities like acute care hospitals and rehab hospitals and skilled nursing facilities, those use a little bit more of Med A. And the supervision requirement is different for Med A than Med B. So you could, if you are in line for a position now, or you already have secured it in an acute care hospital, they may be staffing on site to provide that coverage, and with good systems to help track that Medicare status so that if somebody's Medicare status changes, they can kind of go on the fly, make that adjustment. And if you're looking at positions in adult-focused, hospital-based outpatient departments or adult-based private practices, you can still work in those. You just need different layers of supervision. And that's not adjust, I recognize that, but it's important to make that distinction.
Awesome. There was a follow-up question that kind of came through the chat that's kind of tied to this. Someone mentioned that if the supervising SLP is in another building across town, but serving the same facility as a CF and the sister building, is the CF allowed to treat bill Medicare Part A patients?
I would defer to any of my colleagues who can state with authority, but my understanding is it has to be in the same physical building. And because that person needs to be able to sort of jump in to help if required. Is that everyone else's interpretation as well?
Yes, I agree with you, Brooke. I think Med A is in the facility and Med B is in the room, but I can copy and paste some language from our news piece with a little more clarity on that.
Thank you. All right, so now we kind of know about the settings and kind of work versus bill and that balance. A lot of questions that kind of came through the registration was around just the provisional license itself. So do all states require a provisional or temporary license? Becky, could you give us a little more insight on that?
Sure, sure. As of 2012, all states do have state licensure for speech language pathologists. So everyone does need to have a state license in order to practice as a speech language pathologist. Currently, North Dakota is the only state that does not require a CF to be completed, or a 9-month, I should say, a 9-month supervised experience. So North Dakota would be the only state where you would get a full license upon graduation from your program. All of the other states offer, it has different names. I was trained in Ohio, so I had a provisional license. Some call it a temporary license, some call it a conditional license. But all that means is it is essentially a license to practice while you're completing your 9-month clinical fellowship experience. So yes, with the exception of North Dakota, everyone has some sort of qualified license. And that seems to be the sticking point right now with CMS, is whether or not licensure in their regulations means any licensure or full licensure. And that's kind of the words that we're getting stuck on and are going to really use to advocate.
Right. So another kind of question again with having the provisional licensure is kind of why does this field have it when other healthcare professions might not have it or don't have it? Monica, could you give some background on that?
I can try because I cannot speak for other professions licensure processes. But what I do want to clarify is SLPs are not the only profession who have provisional licensure. The closest parallel I can draw is to clinical psychologists who have a similar process, similar training period, such as a clinical fellowship. They requires, and depending on the state, they require anywhere from 1,500 to 3,000 supervised clinical hours after graduation. And they are within that, they're covered by a provisional license while they provide those services. And social workers, as I've come to understand, have a similar period as well. So clinical social workers. So I do think there are other professions that offer provisional licensure as a model in working towards full licensure. What we haven't seen in our environmental scan is any changes in qualified provider status or billing as it relates to other professions, as it relates to CMS specifically. So that also gives us another argument to present to CMS to say that the interpretation seems uniquely disadvantageous to speech language pathologists. So yes, short answer, other professions have provisional licensure, but they do not seem to be impacted the same way at this point for Medicare Part B billing.
Okay. So we have a couple questions that have come in through the Q&A. So one question is, would ASHA consider changing their policy during this time to allow for full licensure without CF completion, contingent upon being enrolled in a CF?
I can speak to that one if you like. So it's important to think about the distinction between ASHA certification and then licensure being something that is regulation from the state. So ASHA certification is not required. It does not carry a legal right to practice as a speech language pathologist. So to answer if, ASHA would ever consider allowing for people to be immediately certified after the graduate program, that's actually up to the Council for Clinical Certification, which is the group of volunteers who are all certified ASHA clinicians in audiology and speech language pathology, and they actually determine the certification standards. So while that, anything that is in the standards can be discussed and changed, if the CFCC makes a recommendation and then ASHA membership as a whole has an opportunity to give feedback on that before decisions are made. Even if that were to occur, it is a lengthy process. So it's not something that would happen in the near, very near foreseeable future, if it happened at all.
Thank you. I'll ask the question. I think part of it was already answered by what you just shared, but someone had asked, the clinical fellowship hours requirement is per ASHA rather than per CMS. Can't this be mitigated by ASHA to support the developing clinicians?
I think, oh, go ahead,
Yeah, go ahead.
Amanda.
No, go ahead, because I actually, honestly, I'm not sure I quite understand the question, so go for it.
Sure. I think what's tricky is we get into the state licensure issue. So even if ASHA were to make that change, and as Amanda said, that would be a process. But even if we were to make that change, that would have to be changed at the state licensure level as well. So the provisional license exists at the state level. And so even without the ASHA CF, you would still be a provisional license holder until the state board makes that change. So that's kind of an added layer of complication there.
Thank you. So just going through a few more of the questions in the chat. So one other question was, if all notes are co-signed by a supervisor, can it be billed without an issue?
I can start that question. I think this is a can it versus should it question, and it's a little bit of a sticky wicket to define what issue is. CMS's requirement, as we're discussing tonight, is based on your licensing status, not. So you would need to show that you had the level of supervision that is required. So it wouldn't meet the standard. I'll say it that way for a CF who is seeing a Med B patient without that over-the-shoulder supervision, to even if the supervisor signs the note. So if you've been doing this for 7 months and you are feeling very independent and nothing has changed with your client, with you, with anything except for the CMS and the CMS standard, then that's what's changed. So that's the thing that then has to be met. So just having somebody sign off is not enough in the eyes of CMS. And if anybody has a different perspective, please say so.
Yeah, I agree with you, Brooke, because it really comes down to that supervision piece. So if you're not being supervised in accordance with the regulations and they're just signing off, that really doesn't meet the standard. I'm going to drop in the chat here from our Q&A document, something that talks a little bit about billing under your supervisor's NPI, but I think the supervision piece is key.
Thank you. So another question similar was like, is that wouldn't SLP be more comparable to PT or OT with healthcare professions which do not require provisional license rather than clinical psychology?
I can respond to that. Yes, as a rehab profession, certainly. Another thing to note is that each profession is regulated very differently under different licensure boards. And a related thing to note is the movement towards a clinical doctoral degree within physical therapy and occupational therapy, where they are, in theory, obtaining additional clinical training that is supervised within the doctoral degree model itself, as opposed to speech language pathology, where we are paid professionals who are in the clinical during that clinical fellowship year.
Thank you. All right, so there are a few questions tied to kind of next up with CMS. We're going to kind of get to those closer to the end of the event. I want to cover a few other questions that came from registration, because with kind of being in this flux, there's a lot of confusion. And one of the areas is that there's a lot of confusion and concern around the implications for those that are pursuing the CF and their Cs. So Amanda, a question for you is for CFs who have been displaced from roles. How might this impact their certification application process? Is there something that you should be doing now if they're possibly in transition from placements?
Yes. So to be eligible for ASHA certification, your clinical fellowship has to meet all of the requirements that are in the certification standards in place when you apply. So right now, those are the 2020 certification standards, and I will put a link for those into the chat in just a few moments. So standard 7 is the standard that gives you all of the requirements of the clinical fellowship. Anytime you have a question about the fellowship, what counts, what doesn't, what should I do? The first step is you want to go look at the standards, because if it is written in the standard, then it has to occur in order for your fellowship to be considered complete. As far as reimbursement is concerned, the standards don't require that the hours need to be gained through paid or billed services. So this means that if you've already completed hours toward your clinical fellowship, then the CMS changes don't impact the hours that you've already completed. But, and this is a really important but, there are steps you do have to take anytime you change jobs or mentors, regardless of the reason. So if you were displaced because of the CMS update, then you want to make sure that you do 3 things to ensure that the time that you've already put in can count toward your overall experience. Number 1, your mentor must complete the Clinical Fellowship Skills Inventory, the CFSI, and must give you a final feedback session if you want to count the time that you've already earned towards your CF. If you've already left the position and that didn't happen when you left, it's okay to have a meeting with the mentor now and get that done. And that meeting doesn't even need to be in person. But you do have to have that done, because ultimately, when you submit your application and you put in the information from that job, your mentor is going to have to verify the dates and that the hours were accurate, that they gave the supervision necessary, and whether or not you earned a level 2 or higher in all of the clinical skills. So you have to do that tool with them when you're done. Don't panic if you haven't reached a level 2 and you're only partway through the clinical fellowship. That's okay. And in fact, to be expected in most cases, as long as at the end of your clinical fellowship, at the end of your 3rd and final segment, you've hit the 2 or higher on the CFSI, then you're good to go. So that's number 1. Number 2, you do have to get at least 6 hours of direct observation and 6 hours of indirect observation or indirect mentorship activities with each of your mentors during each segment of your fellowship. It's also during each partial segment. So if you are working in a position, and let's say you complete a full segment with your mentor and you got all the supervision necessary, and then you were only partway through your next segment with that same mentor when the position ended. If you didn't get the 6 hours direct and 6 hours of indirect in that partial second segment before it ended, then that time cannot count as part of the second segment. Again, don't panic, and I don't want to overwhelm with too much information. So I just want to say, if you are in this scenario, please reach out to the certification team. Will help to guide you. But basically, you do have a couple of options. You could extend the time frame of that initial segment where you did get all the supervision. You could tack all of the time into that first segment. It's, a segment is about 1/3 of your experience. It's always okay if a segment needs to be longer than the roughly 420 hours. Like I said, don't panic, just reach out to us if you are in that scenario. But really important to know, your next mentor and your next job cannot make up the time that the first mentor wasn't able to provide. Last but not least, it's really important to make sure that your mentors meet the supervision requirements before they begin as your mentor. Because if not, anytime that they mentor, anytime you did while they were your mentor won't count toward your fellowship. And I bring this up, it's important across the board, and it is the fellow's responsibility to make sure that the mentor meets the requirements. There's a link that I'm going to put in the chat. You can verify right on the ASHA website. All you need is the mentor's name and the state where they work, and it'll tell you instantly. The reason that I bring it up, though, is because in these scenarios, it's possible that employers and supervisors are going to be scrambling a bit themselves to try to, get additional folks who can serve as mentors. And so, sometimes, when that happens, if somebody wasn't expecting to be a mentor and now they are, they may not have had time to prepare or even realize that there were steps that they needed to take as a supervisor before they could start mentoring you. So those are the three things that I would recommend, and anything else, please always reach out to the certification team, okay?
All right, I was popping those 2 links for the skills inventory and the certification
Thank you.
process into the chat. So please be sure to grab those. So thank you for kind of covering like what CF should be doing and making sure to kind of do that tracking necessary. We've also heard that some students are kind of hearing that offers are being rescinded or offers are being kind of delayed. So some employers are delaying hiring decisions because of this change. How should applicants navigate conversations with them while they're kind of navigating the kind of the unsure, the in between? Brooke, do you have any perspectives on that?
Yeah, sure. Thank you for that question. I think it's an important one. How's my volume? Am I doing okay? Yeah, okay, great. So first of all, I would say if you find yourself in that position of some hesitance or a change in the offer, to just know that this isn't you. This is not a statement on your value or your worth or your candidacy. It's really about how Medicare policy intersects with these licensing timelines and capacity for meeting these standards. It's also important, I think, to hold in mind that right now these employers are adjusting too. This is a period of no one quite knows what to do, how long that this is going to be, the context that we're trying to work in. So employers are kind of making some trying to figure out their own risk liability, their own standards, their own things that often have to travel kind of up some pipelines. So if you've had a recent interview or a recent offer, that company may be in the background kind of sorting out what they're going to do. So there's still some room there. I think you can use the ASHA policy as a conversation tool. I think it's worth kind of bringing that in and taking it on the like coming right at it. You don't have to be the expert in that, but it does help to walk in informed. And I think you could even frame it like, I know that Medicare updated its policy and there's some new language about provisional licensees. ASHA's explained how this works. Can we walk through this together and discuss how it applies to the position? I think asking these clarifying questions shows that you are thinking it through and that you're willing to be in partnership with this in this relationship. So you can ask questions like, how does your team typically supervise clinical fellows in Medicare settings? Are most of your patients covered under Med B, or is there another payer mix that I can kind of move in and out of? This kind of language, I think, is showing that you're willing to be proactive and you're probably thinking of things that the supervisor may not be, particularly if that supervisor is not a speech language pathologist. In a lot of healthcare settings, you might be supervised by an occupational therapist or a physical therapist or some other health professional. And kind of educating them about what the options are can be a powerful tool. And then I think lastly, I would just encourage to look at it like a door that is still open. So even if it's not a right now, to stay in touch with that employer, to show your interest, check back, learn a little bit more if you can about their current staffing. How often do positions become available so that if it's not right now, as soon as they are able to bring you on, that you are still in their pipeline and still in front of mind with them.
No, those are great tips. I mean, it's definitely one of those things that we've been hearing that there are some employers that are trying to find a way. If they find if you find good talent, you don't want to lose them. So we've heard that some are switching them to peds patients for the time being, maybe, ensuring that the funding sources aren't ones where they have to provide that level of supervision, which kind of speaking of getting more into those payer models and that payer source. So Becky, if someone is looking for a new position, what questions should they ask about the populations that they serve and their payments mix, like their payment sources? Because, until we know more about this issue, that's going to be kind of the question of like, hey, will I have a full caseload? What's that going to look like? Like what questions should people be asking during this time period while
Yeah,
interviewing?
definitely. And to Brooke's point, I really echo that. Being aware and being proactive on this will really be helpful. I think in building a relationship with the employer, but also, in protecting yourself. So you really want to get to the heart of the question, which is how many folks that you expect me to see are Medicare beneficiaries and how many are going to be impacted by this rule change. So we had discussed a little bit about school settings or pediatric outpatient settings or early intervention. You can ask that question. I would guess that the Medicare number would be fairly low. in that setting, whereas if you're in a skilled nursing facility, maybe a neuro outpatient department at a hospital, that could be much higher. So I think, asking the question about how many Medicare beneficiaries are served in that setting is a good question. And then just having that conversation and letting them know that you're aware of these changes, make sure that they're aware of the changes, and just being very transparent, letting them know, even sharing some of our resources that, we're working on this issue as quickly as we can. We don't know that this is the be all end all decision until we get clarity from CMS, but let them know that that's happening. That kind of protects you from getting into a position where all of a sudden, you have a position and then they rescind, but kind of being proactive with that and letting them know that you're aware of the issue, make sure they're aware of the issue, and finding out the case mix. If it's going to be mostly private insurance, then maybe it's really not going to be an issue at all, but it really is just going to depend on that. And that's something the employer would have information on.
Okay, well, before we're starting to see more questions in the chat, specifically focused on kind of advocacy, next steps process. But before we kind of go to that section, there was somebody that kind of asked for kind of a reconfirm. So could you confirm once more, under Medicaid Part B, working in an adult outpatient center would require the mentor to be in the room for sessions?
Yes, let me double check this because I want to get this exactly correct. So Medicare Part B would be supervision as if you were a student, and that is in the room supervision. Whereas Medicare Part A means someone has to be a fully licensed SLP in the facility and present in the facility at the time that you're treating. I'm going to look to my colleagues to double check. That is correct. Yes. Okay. Excellent. Excellent. And we do have that language here in the chat that you can refer to as well.
I will add one more piece to that supervision component for Med B, that it's in the same room, but the supervisor is not supposed to be engaged in other activities. So I think the solution of just treat in the rehab gym and we'll all do it, that would work. That doesn't meet the Medicare standard as it's written.
Right, and that could open up your facility to risk if they see that the supervisor who is supervising is also billing independently at the same time. That would be a red flag.
All right, thank you for clarifying that. So we're now going to pivot and kind of talk about advocacy and next steps. A lot of questions are kind of coming through about how is ASHA communicating with CMS? I know with the message that was sent on June 9th, both from ASHA and NSSLHA, we said that a meeting was being sought. And so kind of where are we? So kind of what's happening now?
Yes. So how are we communicating with CMS? Every avenue that is available to us are ways that we're communicating with CMS. As we're all aware, under the new administration, there has been a limit on CMS staffing and also the availability of CMS staffers to engage external stakeholders and schedule external meetings. So that's a little bit of a hurdle that we've been dealing with since mid-January. The contacts that we had at CMS maybe have not been as responsive or may no longer be at CMS. It's just been a bit of a challenge just due to that environment. So, the initial contact with CMS was via email, and we have been seeking a face-to-face meeting with CMS for clarity. And it's a top priority. We're doing everything we can. We're leveraging our network. We are working in coalition with other organizations who employ speech language pathologists. We just recently sent a coalition letter with several other organizations. We have a petition that we'll share the link for in a little bit, but we have over 20,000 signatures on that petition, and that will be going to CMS tomorrow so they can see the number of people impacted by this decision. So it is very frustrating to wait. We all want the answer yesterday, if not 2 weeks ago, but just know that we are doing everything we can. We are leveraging our network. We are pushing every button we possibly can to get CMS to respond to us and take a meeting.
Thank you. So we're waiting for the meeting, but what's the kind of holistic strategy around this? What is ASHA seeking from CMS? Monica?
We want to few things, and I think it's important to clarify that all different stakeholders in this who are dealing with this issue want the same things. We want CMS to clarify the language around licensure. The key thing to note is when SLPs were given the privilege of billing Medicare under the Social Security Act, and I'm going all the way back to 2008 here, there is language there that indicates that we are eligible under state regulatory mechanisms. We are making the argument that provisional licensures that our clinical fellows hold qualifies under that language of state regulatory mechanisms for billing. So we want written clarification of that policy, so we're not revisiting this in the future. And the other piece to it is, while they are sorting out the language and implementation and interpretation of this, we also want to make sure that we are asking for mitigation of audits and recoupment. So in the context of enforcement discretion. So this can't be retroactive to, at this point, 10 years, right? So we want to make sure that we have a time frame looking ahead for implementation so that both practitioners and their employers can adjust to whatever new interpretation is being handed down to us. But at the end of the day, regardless of whether it is a trade association, an employer, it's ASHA, it's individual practitioners, what we're asking for is clarification and around inclusion of provisional licensure within the broad language of state regulatory mechanisms.
Thank you. So I'm going to go to the Q&A for just a sec because some of the other questions were like, we're taking this approach with CMS, but what about the state level? What's needing to happen or is happening at the state level?
So we have had conversations with state associations who've reached out for clarification, state licensure boards that have reached out for clarification. And honestly, at this point, everyone is in a holding pattern until CMS issues clarification. Opening up state practice acts or revisiting provisional licensure, for example, are all potential possibilities that any state can undertake, but it involves a significant timeline and commitment of resources that everybody wants to rethink if they don't have to do it. So the easiest solution would be, again, like I said, CMS clarifying that provisional licensees are absolutely okay to bill Medicare Part A and Part B as independent providers. And if that's the case, I think that's the easiest solution. But yes, we've been engaging with state associations and state licensure boards who are very much part of our group of stakeholders.
No, I know a great number of them have been posting the petition and helping to get more signatures. So I think, again, everyone's super aligned of getting this fixed and everyone's really committed on that outcome. So one other kind of question that we're kind of seeing is that, given where we are, how can students and new grads advocate during this time? Like, what should they be doing to kind of elevate and bring spotlight to this issue? We've shared the petition in the chat. We'll share it again at the end of this event, but are there any other things that they could be doing now?
Yes, the petition I think is number one for right now. That's the most timely. We're working on using that petition to secure a meeting in a much faster fashion with CMS. So that's number one. And then number two is we do have a form that talks about the impact of policy changes on SLPs. And so sharing your personal story, if you've been impacted by this, if you've had a job loss or an offer rescinded or difficulty securing a CF because of this policy, sharing that story with us is very helpful. We can use that when we're working to advocate on your behalf, having those personal stories. We can do that, anonymously. We can just say, a clinician from this state, however you would like that to be done. But having those personal stories to share can really have an impact, especially when we have a number of them. We can say, this isn't a small issue that's impacting only a handful of people. We can really show the volume of folks impacted, and we can talk about really the emotional side of this as well. Again, many of us here on the call are medical SLPs. We know what it's like and how exciting it is to get that, medical CF, and how challenging that can be to get sometimes. And the excitement, and then to have that rug pulled out from under you is just crushing. So we really, really empathize with you, and we know it's just a really, really tough situation. But if you're able to share those personal stories, we can use those to advocate on your behalf.
Thank you. So I posted that link in the chat. So please share those testimonials and information. It's going to help ASHA advocate with CMS. Those stories are what matters. It's what helps to paint the whole picture of what's happening here. Because a lot of times in those agencies, it's very easy to ignore numbers and kind of like, oh, okay, whatever. But like, oh, wait, this is impacting rural communities. This is impacting our most at-risk populations. It's really impacting our voters, that type of thing. So one thing that's kind of come through the Q&A was one person has asked, what stops other insurance companies from following the steps of CMS? What steps is ASHA going to take to advocate for CFs going forward?
I can speak to that a little bit. As of right now, these changes are only for Medicare, but we do know that Medicaid agencies, and each state is different for Medicaid. They all have their own rules and regulations, and private insurers who also, we call it the Wild West with private insurers, because all of them have their own policies and regulations. Sometimes they do follow Medicare's footsteps. We haven't seen much evidence of that yet. We know there's been some issues with TRICARE, which is military insurance. I'm having some issues with CFs that's been ongoing for a little bit of time. But I think, the same things that we're doing with CMS, showing that CFs are not students, that they are highly qualified, that they have graduate degrees, they have passed a national exam, they've completed their supervised hours, and just really illustrating for regulators the difference between a graduate student clinician and a CF, and how they really are in two different categories. These regulators don't always know the profession and the field very well. We sometimes have them think that CFs are similar to assistants, but again, that is not the case at all. The education is different, the training, the credentials are all different. So really just continuing to educate, and again, let us know what you're seeing. If you see any private payers, if you see Medicaid agencies, please shoot us an email and let us know so that we can extend our advocacy to those organizations. Once we have a response from CMS, we are also considering proactively reaching out to other payers as well to let them know, especially if CMS does reverse this decision, to make sure that they're aware of that.
Thank you. So one thing that's kind of coming up in the Q&A is that, Medicare offered this clarification, but we're asking for additional information. And why is that? I know I know ASHA had a CEO chat last week, and they kind of are saying that in some documents, it's referring to a different provision, and then in others, it's referring to this one. Could you give more background to that?
Absolutely. So there are still documents and guidance documents issued by CMS that have conflicting information and refer to the 2009 standard, which includes clinical fellows and provisional licensees in the language under qualified providers. So the CMS's interpretation of this has not been implemented consistently across all of their guidance documents. So that is one of the reasons why we want to get clarification. Now, the clarification is not specific to whether provisional licensees are included or excluded from being qualified providers, because that's what CMS has already clarified. What we want, what our advocacy with CMS right now centers on is pushing back on their interpretation to say, this does not make any sense because since 2009, we have been qualified providers under the language in the Social Security Act. That has not changed. Your interpretation of this has changed, and we want to advocate against this because our provisional licensees are fully qualified providers. And so that is the conversation we're looking to have with CMS in person. That is the conversation we've already had via email communication. And that's the conversation we want to have with CMS as a group of stakeholders as well. So CMS has multiple documents related to multiple settings and areas of practice. There is not consistency in the guidance that you can find online right now. We definitely want to make sure that whatever is being said is communicated back from CMS, is written out as clarifying policy that's relevant across practice settings that bill Medicare Part B.
Yes, and to Monica's point, we don't want to have to go back and re-litigate this whole process. We want to have absolute final clarity and make sure that everyone is 100% crystal clear on this moving forward, so we avoid any kind of situation like this in the future.
Thank you. So one thing that's also kind of coming up is kind of, all right, the question is, what led to this change? Like what was how does CMS benefit from having CFs no longer being able to bill for these services? There's a little bit kind of like, well, why would they do this?
That's a really good question, and one that we would like to know as well. Because honestly, the way we're looking at it is it impacts providers and it impacts those who are receiving care. So it has a negative impact on access to care as well as the pipeline of providers who are able to provide this care. As it stands right now, I find it hard to articulate how CMS gains from this change in interpretation. So that's exactly it. We're like, nobody is benefiting from the change in your interpretation. So let's not change this interpretation and get clarification in writing.
And it becomes a patient access issue. And I think that's the piece that we're really going to hit hard with CMS is that I want to say we have about 10,000 CFs a year. And, not all of them are going to be in the medical setting, but those who are in the medical setting could be impacted. And it's going to impact access to care for Medicare beneficiaries. And obviously that would be very detrimental to the folks who rely on Medicare for their healthcare.
No, I mean, again, it's one of those things where, we've got patients that are not being served, and that's why it's not just the CFs feeling the pinch, it's the employers feeling the pinch, it's the medical system feeling the pinch, the payers are feeling the pinch. So it puts us in a good position for coalitions and having enough people raising their voices and their perspectives about what to do about this. So speaking of kind of other people that can offer support in this issue is, how can supervisors support provisional licensees and CFs during this time? We have just a few more minutes in the event, and so we want to make sure that they also have some steps and tools that they can apply.
Sure, I can start with that one. So supervisors, I think one of the biggest things you can do is champion within your organizations. I think we want to look at it from kind of fight the good fight right now to create space for people on provisional licenses in these settings, as well as supporting the actual professional that's there. So getting oriented to this policy landscape is a great first step. Again, supervisors don't need to be Medicare experts, but understanding these nuances, and communicating them up to your administrators, to the people who make the decisions about staffing, productivity, those kinds of things. and really supporting all of the benefits that a new grad or an early career professional bring to your organization. The fresh eye on research, the latest in training techniques, all of the real value that you don't get if you or you may not have as rich access to if you're only focused on later career professionals. Being really proactive about supervision models, being creative, looking at those case mixes and figuring out, okay, we've got some people over here who aren't Med B, so let's create a pathway for these professionals to work. And then again, reporting those up, showing that pathway to your employer. That's sort of the make space piece of it. And then really just helping the CF navigate uncertainty. Like we are all, no one feels good right now. This is a time of real in uncertainty. And folks who are students, new grads, early career professionals are just really just recognizing how much stress is sitting alongside whatever it is the rest of their doing, and really acknowledging that and keeping it in mind as you create that mentor and supervisory relationship. Amanda, do you want to add anything else?
Thank you. Yeah, I will add for your clinical fellowship mentors, because I also do want to make the distinction between your supervisor. You might be talking about your employment supervisor, the person who's, in charge of your department or, in charge of your SLP, yourself and your colleagues. Your clinical fellowship mentor may or may not be an employment supervisor. So I'm going to talk about the mentor. If you are in a position or will be in the position to be a clinical fellowship mentor, please take the time now to double check whether or not you meet those supervision standards. You can use the same link that we put in the chat already to verify. Things happen that, your Cs may not be active and you're actually not aware of it, and that can be remedied. When you see that, there are steps to be taken there. Many times it has to do with whether or not the 2 hours of professional development and clinical instruction have occurred, and you can self-attest. So if you look and it says that you haven't completed those hours and you know that you have, you can go into your account and self-attest that you have. So there are some easy fixes to be done. And the other thing that I would say is, particularly if you know that there's some volatility in your own workplace and that there might be a question of whether, this position might be terminated, please be proactive about getting the supervision hours in immediately. You can always do more if it ends up that things, are great and the person is able to stay in the position. But if they don't get the hours that they needed, that impacts how much time they can count.
All right, thanks so much. So I'm going to post a couple links in the chat for everyone, which includes a repost of the petition, the policy feedback form to show the impact that this is having on you. This is where you can share your stories, whether it's that you've had offers rescinded, you've lost positions. It's that real impact, because that's going to help tell the advocacy story when ASHA meets with CMS. In addition, follow the advocacy news on ASHA's website. They post a lot about different issues that are coming out, particularly around this, as well as anything else affecting CSD. In addition, for those that are navigating certification and that process, check out our new grad checklist. It includes that skills inventory. It has the step-by-step guide. It also makes references to state licensure, as well as having career resources and information. In addition, we have our event survey. So with National NSSLHA and having this event, one of the things that we will be working on over the next few weeks is producing additional resources, as well as putting together a micro mentoring program, because we know that a lot of people have been displaced and are trying to navigate these changes. And we want to create spaces where you can find support, information, and resources, because we hope that this all gets resolved quickly. However, with navigating any type of bureaucracy, there's no telling how the agency or how quickly an agency will act. So what we can do is support and show up for one another. So we are asking you that if you have not already signed the petition, to sign the petition. It can be signed by people who aren't members of ASHA or NSSLHA. Share it with your family and friends. We have nearly 21,000 signatures on it so far. The first send to the agency is going to be tomorrow. So please, 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 we have it on our Instagram channel, so you can like, post, or share from there. I am going to just do a quick share of a slide that if you had questions that had maybe a little bit more detailed information about your own personal unique situation, please email reimbursement@asha.org. The team here can help answer some additional questions, as well as that reimbursement team, who are fantastic, and they try to respond as quickly as possible and as much detail as possible. If you have questions about access to the recording, this recording and some follow-up Q&A information will be posted on Thursday, but you can also reach out to nisla@asha.org with additional questions. Thank you so much for joining us tonight.